Okay, so right now our first speaker is sponsored by Ogden Regional's Medical Center. So please stand up if you're associated with Ogden Regional. If you're here with Ogden Regional at all. There you go, we got a couple people. All right, so this one is Dr. Gurjeet Grover. So everyone, let's welcome Dr. Gurjeet Grover.
Good morning, all. I'm Gurjeet Grover, one of the pulmonologists in the area, practicing for past 12 years, and I see some familiar faces. Most of them are retired. I don't know. Well, I am affiliated with all the hospitals in the area, so work primarily in the ICU. I have also practiced outpatient pulmonary. So today, I'm going to talk about some COPD and asthma. I speak fast. So a couple of reasons is one is, as you see, I'm Indian origin, and the second is, I don't want my listeners to ask me more questions. They want to just keep on guessing. So that's why I speak fast. But if you want me to speak slow, I'll do it. And I'll keep it a little boring because I have another speaker coming after me, my dear friend Chris Parr. He's not here, right? No, he's not. He will entertain you, he told me. So, well, I do not have any financial disclosures. I'm going to jumping around because I will talk about three different topics. The first one is about the asthma. Just want to give you a small background on the pathophysiology and then quickly jump on some changes which have happened in the past 3-4 years, maybe more than that. Some for you may already know, some maybe it's new for you, and some it's just a repetition of what you guys know. So the asthma is, as you know, we all know is a type 2 hypersensitivity reaction. So that's why they categorize asthma as type 2 and non-type 2 or low type 2. Type 2 is basically hypersensitivity reaction. So the type 2 is primarily is eosinophilic predominant, is the a disease which responds to inhaled corticosteroids, and it's mostly due to seasonal allergies. The non-type 2 is basically a disease which is really not responsive to any treatment as such. And nobody knows the pathophysiology of non-type 2. It starts with it's neutrophilic predominant. It's mostly adult onset asthma. Adult onset asthma is very rare. If somebody diagnoses adult onset asthma, they will think multiple times is really asthma. There are many studies they've shown that 60 to 70% of the asthma diagnosed in the primary care is actually not asthma. And multiple in both in US and Europe as they have seen it. So, but we also have to rule out other diseases. There are other diseases which I'll mention briefly later on. So type 2 is basically not responsive to steroids, neutrophilic predominant. So briefly about the type 2. The pathophysiology of type 2 is very well understood, but the non-type 2, low type 2 is not understood. I will just briefly mention. So type 2 is very similar. I think you probably go back into your second year med school, is allergens, pollutants, which basically join the mucosal epithelium and activates these. We call this as cytokine, epithelial cytokines, IL-33, IL-25, TSLP. TSLP is thymic stromal lipoprotein. 25 years ago, maybe they did not know about these things. These are also called alarmins. These in turn activate your type 2 helper cells, and then these in turn activate B cells, which basically produce IgE, and then activates the mast cell and basophil, which basically plays a significant role in asthma. And also, these type 2 cells also activate through the IL-5, interleukin 5, activates eosinophils, and then it leads to smooth muscle proliferation and sort of like a hyperresponsiveness. So non-type 2 is really not understood. They think all these environmental agents, infection, pollutants, all these things, through these receptors called, I'll just briefly tell you, TLR is basically toll receptors, and PAMPs and DAMPs are basically pathogen-associated molecular patterns and damage-associated. Damage means they damage the epithelium, and then in turn, these receptors activate the epithelial cells, and then through the interleukin, activate the neutrophils, and then cause inflammation, and then basically smooth proliferation and hyperresponsiveness. The reason I'm talking about these two is because the new agent, the advances which have come in asthma basically target some of these interleukins and to block their pathways. So how many have you heard about the exhaled nitric oxide? How many of you use exhaled nitric oxide? This is not new. This is 15 years ago. Exhaled nitric oxide is basically produced through our mucosal airways in called dilatations. It's vascular as well as bronchial. So initially, they thought it's all produced by the mucosa of the upper airway and the sinuses. But they found that it's actually not. It's actually mostly produced by the lower airway. And you can measure, this device you can measure. It came up with this around 15 years ago to measure the exhaled nitric oxide. The clinical significance, obviously, is one is the differentiation between type 2 or low type 2 asthma. And then the other thing is, when you start, if you really type 2, sorry, then you start the treatment, you can follow. It's just like you follow peak flows. So a lot of academic centers, they follow. I don't think a lot of people have this in the clinical practice. We also do not have it. But I was trained in it, and we used to use it in a clinical practice at that time in our fellowship. So you select the treatment and also see how they're responding to treatment. And if they're not, then you adjust the treatment based on it. So in adult, the fractional exhaled nitric oxide, if it's greater than 50 parts per billion, shows eosinophilic inflammation, and then if it's in kids, it's greater than 35. So asthma itself nothing has changed from the management. It's still a stepwise management, which GINA, Global Initiative of Asthma, basically came up with this in 2010 or 12, something in that way. Is a stepwise approach. A stepwise approach, you stepwise go up and stepwise come down. You assess the response and you change the treatment. There's constant adjustment needed. So 2012 GINA and you stepwise is initial treatment for asthma is obviously when you start, if it's depending upon the severity, and obviously, you start with the as needed in shorter acting bronchodilators. And then you go up to inhaled corticosteroid, and then if that's not responding, if they're not well controlled, then you go to combination of inhaled corticosteroid and then longer acting bronchodilators, LABA, and then you keep on going from lower dose to the higher dose. But 2019, GINA came up that if you use short combination of inhaled corticosteroid and LABA, longer acting bronchodilators, as needed for initial treatment, actually it's basically proven to be very beneficial in a way that there are 4 studies. Initially started with Europe, and then US followed. 4 studies were done, Sigma 1, Sigma 2, Novel Start, and these are named studies. So to see how, it's not class specific, it's the drug specific. So if you look at it's only this combination therapy of inhaled corticosteroid and LABA is only for budesonide and formoterol. It's not studied. The other agents are not studied. I don't want to use some trade names or anything, but the other agents like fluticasone and salmeterol or other agents are not studied in this. It's only budesonide and formoterol. And they found that when you use as needed combination, your usage of steroids is actually low in the period, and then your exacerbation rate is actually also lower. So you can see the studies. It's compared if you compare obviously when as compared to just inhaled corticosteroid on a regular basis, there's the exacerbation is very similar, but overall usage is very low. So this led to GINA to change these guidelines to basically use as needed. So this is just a new change of the past few years. Some of you may be aware of it. So the other thing is biological. I cannot pronounce all these names. I just call them MABs. So there are different agents. Basically, these are biologicals, monoclonal antibodies. In U.S., this is a game changer sort of thing. If you remember, some of you have been in practice in 80s and 90s. I wasn't there. I was like, I still like, I don't know, how old was I? 4 or 5 years. So at that time, I was told that you have, ICUs were full of asthma, status patients. And then came inhaled corticosteroid therapy. And that was a game changer at that time. And now we hardly see any asthma patient in our ICU. I would probably see maybe 1 or 2 status patients in a year. And most of them are not related to, like, it's probably non-compliance or associated drug use or something along with it. So, and now this is a new change. It's basically for uncontrolled asthmas, which are basically on maximum therapy of either your combination therapy of inhaled corticosteroid and longer-acting bronchitis. You also can use LAMAs, tiotropium, and also your leukotriene inhibitors, and the next step would be these agents. So these are the different agents which act on different interleukin and block their pathways. The oldest, is omalizumab, is an anti-IgE, which has been there for many years. The other agents which block the pathway is anti-IL-4, IL-13, dupilumab, and then IL-5, mepolizumab, and reslizumab. There's only one agent in this which is just in the past few years approved, is tezepelumab, is basically anti-TSLP. This is the only agent you can actually use for both type 2, which is eosinophilic, and low type 2 is eosinophilic predominant asthma. So these agents are mostly, obviously the only, it takes a while in the clinical practice is the approval for these agents for the insurance is a big challenge. And once you get that, and then you obviously, you can, I'll show the next slide in the flow chart, how to basically choose the agent. So these are the agents which are basically used on one of is intravenous, the anti-IL-5, everything else is subcutaneous. It's either bi-week, every other week, or every 4 weeks. It's injections you give. So this is a flow chart. This is basically a very good flow chart. The article came in NEJM in 2022. It's how to use these agents, the biological. It's based on your eosinophilic count. It's based on your FeNO, like a fractional excitation nitric oxide. And you can see, I don't want to go because I don't, you look at the eosinophilic count and you can choose what agent you can use. If you have low eosinophilic count and low allergens and low FeNO, TSLP is only agent which can be used is for the neutrophilic. But everything else, like if you have a high eosinophilic count, you just go to anti-IL-5. And if it is in between, based on your FeNO and allergy, you can choose which one is most approved. And then you assess your response of 3-4 months. And if they're not, then you can choose a different agent. I don't think they have studied combination of 2 monoclonal antibodies. So this is a very, how many have, I'm not sure if in the community practice you guys use these agents. Have you any difficulty in getting the approvals and starting it? These agents are also used by our dermatologists also for some other, and also ENT. So So this was thought to be game changer in 2020, 10 and 12, bronchial thermoplasty. Company came and started promoting this thermoplasty, and the studies were not that bad, and it got approved in 2010, I think. It's basically just doing a laser therapy to your airway, doing it in a stepwise approach, one lobe at a time, to see if you can decrease the inflammation. And the data is there. There are two studies done, AIR-1 and AIR-2, and it shows that it decreases severe exacerbation, improves the quality of life, including all these emergency room visits. But nobody knew what is the long-term effect of it. So we still don't know. The data right now is a 10-year data, which is there, is for the that it decreases exacerbation, but there's a significant increased rate of bronchiectasis. So that's why GINA, the global initiative, does not approve this therapy at this time. They said you use it as case-by-case basis. It's not part of the guideline. Okay, I'm just going to jump to the COPD. COPD is basically management, not much change, but a few things have been added. The classification still remains the same. The GOLD 1, 2, 3, 4. GOLD is basically Global Initiative of Chronic Obstructive Lung Disease. And so this is not new. This is basically from 2012. Is you describe severity based on your baseline symptoms and exacerbation risk. It's A, B, C, D. Low risk, low exacerbation, and D is obviously high risk and high exacerbation. So this is 2022, and 2024 they have changed it. The C and D are all combined into E. They call it E now. So basically, you look at this. The CAT is basically COPD assessment tool. This is a scoring system. This is a U.S. system. And MMRC is Modified Research Council. Basically, is a simple system to assess this, how your patients are symptomatic. This is basically the scale you can have easily in your office and assess what category they qualify, and then you can assess how many exacerbations are they getting in a year. And based on that, your treatment depends. I see whenever a new drug comes in and COPD, they all go on the same. I will give you an example. Everybody of COPD, whether it's mild, what category is A, B, C, D, they all go on triple therapy. Triple therapy is inhaled corticosteroid, LAMA, and LABA, long-acting medicine. They all go on. Everybody is on it. I can see all the patients. I said, why you have like very mild COPD or you don't have any symptoms, why you're on this trilogy? Oh, sorry, I use the trade name. Triple therapy. So the triple therapy is on, you can use it at the last stage. So this is a change I want to show you. So this is a basically change. This E is a category. So based on how your symptoms, you have to choose what agent. It's all studies. So LAMA and LABA are the first drug to use for group B, and then you can escalate therapy and come down. Basically, it's a management. Obviously, same, just like asthma, management cycle. You have to adjust. You assess this response, and you either add therapy or you cut down the therapy. If the response ends, you can cut down. Not every patient needs inhaled corticosteroid. So as I said, combination therapy is definitely better than this solo therapy. If you're in that category, it improves lung function, quality of life, and it decreases exacerbation. So steroids are only used if if you have this evidence of exacerbations, your eosinophilic count is greater than 300, you have asthma, all those things. And if you have a frequent history of pneumonias, you have to think again to take them off the inhaled corticosteroid. GOLD, the global initiative, is actually said, if you're getting 2 and more episodes of pneumonia in a year, you need to take them off the inhaled corticosteroids and just use them on just combination therapy, LAMA and LABA. So this is a triple therapy. Triple therapy is very beneficial, but is only for moderate to severe COPD. The triple therapy is these two studies, very large studies done, one in Europe and one in the US, IMPACT and ETHOS trial. They use triple therapy is obviously fluticasone, Vilantrol and what is omecilidum, basically combination of ICS, LAMA, and LABA. It decreases exacerbation, moderate and severe, and actually it also has a mortality benefit also. But these are only used at the last resort, not at the beginning of it. So this is basically a bronchoscopic lung reduction. It's a bronchial valve. So lung reduction surgery came back many years ago. It's a surgical lung reduction. The data initially did not show any benefit on the lung reduction because they were using all patients. But when they did a subset analysis, they found that people who have a very poor exercise tolerance and who have an upper lobe dominant, they basically benefited from it. So then they said they only do surgical lung reduction for those patients. The thought is, obviously, when you take there's all hyperinflation. You take the upper lobe out, the lower lung have more space to expand, and you can, and then basically decreases the air trapping and decrease the symptoms. So then the bronchial valve. There are two valves. There's for inspiration valve. They basically what it does is does the lung reduction by blocking one of the lobes. So this is based initially initially was all IRB case by case basis, but now it's all approved and used. The off-label use of this valve is also for we use it for bronchopleural fistulas. If you have a bronchopleural fistula and leading to this constant air leak from pneumothorax, they can use this by blocking those particular, if you think, the lobes, and then decreases the air this fistula decreases the activity of the fistula, and then the seal sort of off, and then the chest tubes can come out. But this is for COPD. You only use it, but they have to meet the criteria. So patient selection. Patient selection is basically obviously they have to be moderate to severe, but mostly severe COPD. But if they have a heart issues, they have a chronic CO2 retention, bronchiectasis, tumor, previous lung transplant, you cannot use those for those patients. But if you use bronchial valve, that does not mean that they cannot go for lung transplantation. They can still go for lung transplantation evaluation. So how do you select your patient? Is basically it's the radiological. It's a 2 millimeter cut of CT scan to see, basically to look at the integrity of the fissure of the lobe in between the lobes. If the fissure is intact, then only this therapy will be beneficial. That means if you have collateral aeration, if you have collateral ventilation, you cannot use this because even if you block one lobe, the air is going to go from the other lobe and still cause the hyperinflation. So you check for the integrity by this 2 millimeter cut CT scan. It goes into a software, and they can see if this is greater than 95% fissures are intact, then you're good. These are good candidates. If it's less than 80%, you're really not a good candidate for because there's significant collateral air ventilation. If you're in between 80 to 85%, then you can do what's called Chartis assessment. Basically, you go with the bronchoscope with the balloon and you block that particular lobe and see how the airflow is. If you look at this chart, there's nothing there. Okay. So you can see that the flow goes down, and the flow goes down means there's not much aeration. So those are patients who are candidate for it. We have it in our in this committee. I have a partner who does it. If you have any patients, you can definitely refer for these patients and it helps with them. It's mostly symptomatic improvement. Okay, I was asked to talk about whole lung lavage also. There's not much in whole lung lavage. Whole lung lavage basically means you're lavaging the lung with this liters and liters of saline. The only indication for this condition is alveolar proteinosis. We don't use it very often. I have not seen a single patient in this community in the past 12 years. We had 4 or 5 patients in Minnesota when I was in fellowship, and we have this new treatment for this condition. It's called GM-CSF, granulocyte macrophage colony stimulating factor, which is used and we hardly use now, we do any lavage anymore. Basically what it does is you basically take out, you go in and with a dual lumen endotracheal tube and block one of the, you invented one lung, and the other lung, you basically keep on lavaging with 1 to 2 liters of saline to get all this milky stuff out, and helps with the, obviously, the symptoms and breathing. So as I said, with the advent of GM-CSF, we hardly use, this is the only condition. They have tried in ARDS, in other conditions, cystic fibrosis, there's no benefit. Only benefit is this, your alveolar proteinosis. And I think that's it. Thank you very much. Yeah. Gee, any questions? Yes. Yeah.
The use of a combination of inhaled corticosteroid and long-acting beta agonists. That was pioneered by Paul O'Byrne in Canada in 2018. And they're using them PRN.
Yes.
I'm sure. So using a combination of inhaled steroid and long-acting beta agonist PRN instead of regular inhaled steroid and rescue albuterol. One of the keys is he used formoterol. It has to be a fast-acting beta agonist because they're using it as their PRN, as a rescue medicine. And his theory is that you get the inhaled corticosteroid on board quicker that way. You need to take away their albuterol.
So it's only particular drug which has been studied. They have not studied all the classes. It's only formoterol.
And his study used formoterol.
Formoterol and budesonide. There's
And
only two combinations.
That's right.
They have not tried other classes. And you can still use your albuterol as needed, but the reliever, you can use reliever. They recommend that your reliever should be the combination.
I've talked to him. He takes away the albuterol.
Yeah, you can use this, the GINA, the Global Initiative of an Asthma, recommends both. Obviously, I'm pretty sure in the next few years the new guideline would come up will just remove the albuterol completely. Right now they still say your alternative can still be albuterol, but they've said this is more beneficial.
Now,
Definitely.
the guy who pioneered it, O'Byrne, doesn't believe in using albuterol because his theory is you get that inhaled corticosteroid on board quicker when there's an exacerbation. You're using the combination as a PRN.
Yeah. Yeah. Yes, ma'am. You have.
If your type 2 asthma has highest symptoms, non-type 2 asthma has decreased neutrophils.
Yes.
And you react, and you don't react to corticosteroids. What if you have elevated neutrophils asthma, but you do react to response to corticosteroids?
Yeah. If so, the response is not based on I'm gonna look at the. So you still, if you have asthma, if your clinical picture, asthma is clinical diagnosis. If you have asthma, you still treat not based on your neutrophil count or eosinophilic count. You still treat just like your asthma. Now, if you're not responding, that means you're more predominantly neutrophilic. Then you think about, obviously, at any time, if you're adult onset, you have to think, as said, it's not always asthma. 60, 70% is not asthma. It's either your rhinitis, it's your postnasal drip, or is it your, you have AGPA, which is basically Wegener's, or some vasculitis. You have to think about other diagnoses. As said, adult onset asthma is very rare. So.
I was wondering, are you seeing just as much exacerbation, like asthma, with vaping, and the COPD-like illnesses with vaping?
So vaping leads, obviously vaping, any drug use obviously will cause exacerbation. But vaping itself we call it EVALI, basically a vaping-induced lung injury. It's an entity which came up 10 years ago. It basically is the interstitial lung disease, which leads it has airway disease and interstitial lung disease. Very hard, these young patients, it came up and it's not. It's probably initially thought it's not nicotine it's some other agents, or they're what they use along with this nicotine, which is causing it. It's very hard. They can go into full blown in ARDS, and it's sometimes very hard to treat. But yes, it does cause exacerbation, but we always have to say if they have a disease in the parenchyma tissue, then it's mostly called EVALI, is a vaping-induced lung injury. And that's basically you treat like as if you have a organizing pneumonia or interstitial lung disease. And we don't know how we treat it. We treat with steroids, high-dose steroids, and hope they get better. So that's the only treatment option we have. Right. Thank you. Thanks.